Okay, so good afternoon, everybody, and welcome to the MedEClasses postgraduate lecture series. We'll be focusing today on a very important, although a rare but complicated topic of hypercalcemia. Now, when we talk about hypercalcemia, it seems to be rarer, more implications. It would have more implications in terms of the overall evaluation and management, because there are a lot of issues which are there from that perspective. And hypercalcemia is something which is more common in the neonatal period, but you can also see this as part of the subsequent evaluation and assessment as well. So we will be trying to focus about different aspects of hypercalcemia, largely with regards to the overall pathophysiology. Then we will have a discussion about etiology, management, as well as then we'll try to go through a Q&A session, which is specifically done in terms of the helping for the postgraduates in that perspective. So we will start off with this very interesting case of hypercalcemia, wherein there are issues in terms of how a simple case of hypercalcemia may have significant diagnostic implications. So we had this 3-year-old boy who presented with bone pain and had found to have a high level of calcium, where the phosphorus was on the normal level. Now, when I discuss about the pathophysiology, we'll understand that calcium and phosphorus, both of them we have to assess in a proper fashion to achieve a right diagnosis in that perspective. Now, on evaluation, first step you always look at is the PTH level. Now, there the PTH level was low, which was in a way indicated by the phosphorus level, which was normal, because if your PTH is high, you expect the phosphorus level to be on the lower side. So this was a PTH independent form of hypercalcemia. The vitamin D level was found to be normal, and calcitriol level was also normal, excluding a vitamin D form. So often we consider, okay, when you have hypercalcemia, you either have a PTH or a vitamin D related cause. Both these causes have been excluded in this scenario. So what we are looking at is a rare scenario. And what was found, that there was a lytic lesion which was present in this scenario, which resulted in the diagnosis of a lymphoreticular malignancy, leukemia. So hypercalcemia, though usually endocrine, may also have significant component of other disorders which we have to be aware about, and that's why we need to be cautious about. So over the next hour or so, we're going to focus about the practical aspects of pathophysiology of hypercalcemia, evaluation, management, and case-based assessment. All of you are welcome to go to our website, learning.growsociety.in, which has got a lot of resources with regards to pediatric endocrinology, including a lot of training opportunities which are there. We have got a YouTube channel, which has got a lot of information, along with validated courses on different aspects of pediatric endocrinology, including fellowship programs and the postgraduate programs which are available. We do frequent grand rounds along with the approaches and postgraduate lecture series which we are doing today. There are publications and mobile applications which can be used for day-to-day care in terms of pediatric endocrine practice. So today we'll start off initially with regards to the pathophysiology. We will then move forward towards the further evaluation and assessment, and then we'll subsequently look into the etiology and management of that perspective. So when we talk about the calcium level, most of the calcium is actually stored in the bones, and only 1% of the calcium which is there of the total body is actually able to meet with the blood circulation. So it's only this 1% that we are going to focus about when we talk about hypo or hypercalcemia. Now, out of this calcium, around 40% is bound to albumin, and the albumin binding depending upon the acid-base status of the body. Around 10% is bound to phosphorus. So in conditions where you have high phosphorus, you will have a level of calcium levels which will actually go down. Similarly, if you have scenarios where your albumin levels are high, you would expect your total calcium to go up while your free calcium level is normal. And ultimately, it's the free or the ionic calcium which is the most important, which represents around 50% of the calcium in that perspective. So in scenarios, we have often been aware about conditions of hypoalbuminemia, and how hypoalbuminemia causes pseudo-hypocalcemia. Similarly, if you have high levels of proteins because of any conditions, your total calcium levels will be high, while your ionic calcium will be unaffected, resulting in a condition of pseudo-hypercalcemia. So this is something we need to be aware about. So always better to have your ionic calcium, which is measured in that perspective. A word about calcium homeostasis. So essentially, when we talk about calcium homeostasis, we are talking about three major organs which are playing a role and three major hormones which are playing a role. So we have got the intestine, which is the chronic source of calcium, and long-term abnormalities which are there in terms of calcium are related to often to the intestinal absorption. We have got the acute source, which is the bone, which will immediately give the amount of calcium if you have deficiency. And of course, minor player is the kidneys, which is going to retain the calcium. Now, this whole process is regulated via three groups of organs. The most important of them are the parathyroid group of hormones, which are basically hypercalcemic and hypophosphatemic. They will increase the calcium and they will decrease the phosphorus. We've got calcitriol, which is in a way PTH dependent, but it increases the calcium absorption from the intestine, increasing both calcium as well as phosphorus. And finally, we have got calcitonin, which is basically a hypocalcemic hormone. Now, since the body has evolved in calcium deplete state, if you look into that, the evolution for conservation against hypocalcemia is much more as against conservation against hypercalcemia. So calcitonin is a minor player as far as the overall regulation of the calcium homeostasis is concerned, because if you look at conditions wherein the calcitonin levels go really high, if you think about a medullary carcinoma thyroid, where the calcitonin level goes 1,000 times the normal level, still you do not develop hypocalcemia. Similarly, when you remove basically the thyroid gland completely, you're also removing the source of calcitonin and you do not develop hypercalcemia. So calcitonin is a borderline player in terms of overall regulation. And this is very important because when we are treating hypercalcemia, we give calcitonin, it is only effective for some time because there is a tachyphylaxis which develops in that perspective. Now, the body basically senses the calcium level using a calcium sensing receptor. If this calcium sensing receptor is active, your PTH level will come down, 1-alpha hydroxylase level will come down, and the calcitriol level will come down. So in a way, you will be regulating your level in that perspective, and there will be an increase in calcitonin. So increased activity of the calcium sensing receptor, i.e. hypercalcemia, will result in low PTH, increase in urinary excretion of calcium, and increase in calcitonin secretion, which will then try to restore the entire process in that perspective. Now, there are broadly speaking two causes of hypercalcemia. You have got the PTH related causes, and once your PTH goes up, you also tend to lose phosphorus from the urine. So these conditions will be associated with hypophosphatemia. And the second important condition would be that of vitamin D excess. So whether you are taking more vitamin D, whether the body is converting more to 1-alpha hydroxylase, or there is decreased inactivation of vitamin D, whatever cause you're looking at, you will have a high level of calcium along with a high level of phosphorus. So the most important investigation to look at in a child with hypercalcemia is phosphorus. Everybody with hypercalcemia, we expect the phosphorus to be on the lower side because it's usually the PTH related. But if your phosphorus is also high, either you are having more vitamin D in the system, or there is less amount of bone resorption, as in immobilization or hypophosphatasia, or there is increased bone resorption, then in your calcium and phosphorus is high. So phosphorus is a very important thing to look at in that perspective. So just to summarize, PTH increases calcium while decreasing phosphorus level. Calcitriol increases both calcium as well as the phosphorus levels and also increases the urinary calcium excretion. So if you have a high level of vitamin D, you will develop a hypercalciuria. Third important point is that calcitonin basically decreases your level of calcium and phosphorus while increasing the urinary excretion. So it's basically trying to decrease your calcium from that perspective. Now, a very important point which is there when we are comparing the effect of PTH versus the effect of calcitriol, the PTH is actually retaining urinary calcium, while vitamin D is increasing urinary calcium. But still you will have hypercalciuria in the setting of hyperparathyroidism because your absolute calcium levels go high. So for the same level of calcium, a normal individual versus a hyperparathyroid individual, the hyperparathyroid individual will have a lower urinary calcium excretion. Now, what it means is that if you have a vitamin D related hypercalcemia versus a hyperparathyroidism related hypercalcemia, which of this is expected to cause more nephrocalcinosis, Dhwani?
Vitamin D related.
Vitamin D related, because your PTH will come down. And your PTH comes down, you can't conserve that calcium, it will be lost. So that's why if you look at many patients with long-standing hyperparathyroidism may not really have nephrocalcinosis, while often you will see somebody who's taking vitamin D for a long time will immediately develop nephrocalcinosis because this protective effect of PTH on calcium excretion is not there from that perspective. Now, one important factor which plays a role in the overall process is that of calcium sensing. So as I said, there is a calcium sensing receptor which is there in the body, which basically tells that your calcium levels are high. If your calcium levels are high, it will suppress the PTH. It will then go to the kidney and say, okay, the calcium is high. You excrete the calcium, so urinary calcium will become more. And it will go to the calcitonin to say, yes, now we need to increase the level of calcitonin. So if you have an inactivating mutation in the calcium sensing receptor, you will have an interesting scenario wherein the body will say, okay, we don't have enough calcium. Let's increase the PTH level. So PTH will go up and it will say, okay, I don't have enough calcium. I want to conserve the urinary calcium. So this will result in a condition which will cause what in terms of blood and urine calcium?
In terms of blood, there will be hypercalcemia.
Hmm?
In terms of urine, there is hypocalcemia.
So this will be the inactivating mutation of the calcium sensing receptor, which will cause hypercalcemia with hypocalciuria, which is quite the opposite of the activating mutation, which causes hypocalcemia with hypercalciuria. So calcium sensing receptor becomes important. And as we have discussed, there is a sinusoidal relationship between the PTH levels and the calcium. So as your calcium levels go up, the PTH level will really go down. Now, in somebody who has a calcium sensing inactivating mutation, this curve is shifted towards the right side. So for every level of calcium, your PTH level will be on the higher side. In a way, the body is not responding to the calcium. You will have hypercalcemia with hypocalciuria. Now, within this perspective, now if you think about it, what will be the causes of hypercalcemia in that perspective? You could have problems in which your bone turnover is either less, so all the calcium is staying outside, or it's becoming too fast, therefore the calcium is being excreted. You could have problems of absorption of calcium. This is largely vitamin D related. Problems of excretion of kidney, which is mainly the calcium sensing receptor and the thiazide diuretic, and then of course a sensing defect. So bone turnover can be more in the setting of hyperparathyroidism. Any malignancy which is causing a bone resorption or secreting the PTH related peptide, which is causing that scenario. You can have an activating mutation of the PTH1 receptor, which is Janssen's metaphyseal dysostosis. You could have a lytic lesion from where the calcium is coming, or increased intake of thyroid hormone levels, or retinoic acid as well, which will cause these problems again, which will cause this scenario. You can also have decreased bone formation, decreased bone turnover in that setting of immobilization, where bone formation is less. You could have hypophosphatasia, where again the resorption will take over as compared to the formation, and therefore you will have more calcium and phosphorus in that perspective. An important thing to remember is that PTH related causes here will have low phosphorus levels, while bone resorption related causes will have a high phosphorus level in that perspective. Now, in the vitamin D related causes, which will again cause hypercalcemia with hyperphosphatemia, You will have increased intake of vitamin D. You could have increased activity of 25-hydroxylase, or you have abnormality in terms of 24-hydroxylase deficiency, which can cause that. You can have ectopic production of 1-alpha-hydroxylase, classically seen in some granulomatous diseases like sarcoidosis, tuberculosis, in which you have an uncontrolled production of calcitriol, which will cause excess or an impaired 24-hydroxylase. Reduced renal excretion is a milder cause, because we discussed that it is the intestine and the bones which are the major regulator. Intestine is the chronic regulator and bones are the acute regulator of calcium levels. Kidneys are minor players. So in somebody who is predisposed to hypercalcemia, if you give them thiazide, they may develop hypercalcemia, but not on a routine basis from that regards. Sensing abnormalities, as in calcium sensing receptor defect or lithium excess, if there is an inactivating mutation, will cause hypercalcemia with hypocalciuria. So in this regard, we will now move forward towards the etiology of hypercalcemia, and I'll invite Dr. Dhwani to talk about the etiology in that regard.
Thank you, sir. Having understood pathophysiology, it will be much easier to understand the etiology. So, three major causes of hypercalcemia. The first one is an increased absorption, which can be because of vitamin D toxicity. It could either be an exogenous increased intake of vitamin D, 24-hydroxylase defect, wherein your 25-OHD is not getting inactivated to 24-25-OHD, and therefore more of it is getting converted to 1,25-hydroxylase and resulting in vitamin D toxicity. Another important cause in the neonatal period is Williams syndrome, which has both these defects. There is a 24-hydroxylase defect as well as an increased 1-alpha-hydroxylase activity resulting in vitamin D toxicity. 1-alpha-hydroxylase excess is also seen in granulomatous conditions like sarcoidosis, tuberculosis, and may be seen in neonates with fat necrosis, as we've already seen. A minor role is played by the kidney, wherein decreased calcium excretion can result in hypercalcemia, which is commonly seen with prolonged thiazide diuretic intake, and a decreased excretion is seen with calcium sensing receptor defect, which could either be because of an inactivating mutation in the calcium sensing receptor or antibodies to the calcium sensing receptor. Moving on, the third cause of hypercalcemia is a disordered bone turnover. Now, it could again be of two types. Either there is less formation, as may be seen with hypophosphatasia or immobilization, or it could be because of increased resorption, as can be seen with hyperparathyroidism, calcium sensing receptor defect, PTH-related peptide defect, and vitamin A excess and thyrotoxicosis, as we've already discussed. In the vitamin D-related causes, in the setting of vitamin D excess, you will see an increased calcium as well as increased phosphorus levels. Vitamin D excess can be because of increased intake. You must have often come across patients wherein you've prescribed them with weekly doses of vitamin D, but they've been giving it daily. So this is a common history that should be elicited to inquire about the frequency of vitamin D that you're giving to the patients. Another cause of vitamin D excess could be a 24-hydroxylase deficiency and granulomatous conditions, which will increase the 1-alpha-hydroxylase activity. A very important cause in the neonatal, especially the preterm babies, is low phosphorus supplementation, especially in those with prolonged total parenteral nutrition. The low phosphorus will trigger 1-alpha-hydroxylase. Therefore, vitamin D levels will be high. Calcium will be conserved, resulting in hypercalcemia. But until the phosphorus is supplemented, it will remain low and exacerbate the hypercalcemia.
So generally, we can mention that in related or vitamin D related causes, we expect the phosphorus to be high. But if the driving force is hypophosphatemia, you will have a low phosphorus level. So don't get confused that if you have low phosphorus, it doesn't mean that calcitriol is high. The calcitriol is being driven by low phosphorus.
Granulomatous diseases could be infections like tuberculosis, histoplasmosis, or HIV. It could be inflammatory conditions like sarcoidosis or neoplasms resulting in lytic lesions like lymphoblastic lymphoma. Classically, these children will have normal 25 OHD levels with very high calcitriol levels. And because this is a vitamin D related cause, you expect them to have normal to high phosphorus levels. Fat necrosis is an important differential one must consider in a neonate with hypercalcemia. The lesions will typically appear like firm violaceous nodules. This is often seen in the setting of birth asphyxia. And again, this has high 1-alpha hydroxylase activity, so you will see normal to high phosphorus and high calcitriol levels. Williams syndrome has a defect in 7q level. The features are it has early onset hypercalcemia, which is often mild and self-limiting. The classical facies described in Williams syndrome is an elfin facies, and they have a higher predisposition to a supravalvular aortic stenosis. The hypercalcemia usually resolves by 4 to 6 weeks here.
What are the basic cause of hypercalcemia in this disorder?
It is because of 24-hydroxylase deficiency and an increased 1-alpha hydroxylase activity.
If you have less 24-hydroxylase, it basically means that you are not inactivating vitamin D, while you are activating vitamin D more. So these individuals will typically develop symptoms when you actually give them exogenous vitamin D. And once you give that, suddenly their levels will increase. So this is the typical scenario. But as you discussed very nicely, usually you will have facial features and syndromic diagnosis, which is more common. Hypercalcemia is detected when you evaluate. So they are unlikely to present you at that time frame.
Phosphorus deficiency, as we've already seen, it is commonly seen in the setting of preterm neonate on prolonged total parental nutrition, who we have not been able to establish full feeds. Once we are able to put them on full feeds, the dietary phosphorus is usually adequate to meet the dietary requirements. So in the setting of phosphorus deficiency, there is an increased 1-alpha hydroxylase activity. Classically, these children will have low phosphorus with normal 25 OHD and high calcitriol levels. And management is phosphorus supplementation in TPN. Moving on to the drug-induced causes. Drug-induced, the first most important thing is looking at the vitamin D supplementation, whether it has been more than what is prescribed. Other common causes of drug-induced cause of hypercalcemia, one needs to look at vitamin A overdose or thyrotoxicosis. Lithium excess results in calcium sensing receptor defect, inactivating the calcium sensing receptor. Therefore, in this setting, you will see conservation of calcium despite high or high to normal calcium levels. Another interesting thing one sees with calcium sensing receptor defects is that magnesium is also sensed by the same calcium sensing receptor. So this receptor now senses the magnesium levels also as being low or inadequate, and therefore in this setting one may see hypermagnesemia, which is in contrast to hyperparathyroidism, where one will basically have a loss of magnesium in the urine.
So if you are comparing hyperparathyroidism from a familiar benign hypercalcemia, which is the calcium sensing receptor defect, it is the magnesium level which can help you out. If your magnesium is also high, you are more likely dealing with an inactivating calcium sensing receptor defect. While if your magnesium is low, it suggests hyperparathyroidism as a cause, and of course the other will be the urinary excretion of calcium.
We've already seen increased calcitriol either exogenous or in the setting increased calcitriol intake, and often calcitriol excess may be seen wherein intramuscular injections are given to children to increase their vitamin D levels, which may result in drug-induced hypercalcemia. Infantile hypophosphatasia is a condition of decreased bone formation. So these children will present with early onset hypercalcemia, classically because deposition of calcium and phosphorus in bone is less. So these children will have higher phosphorus levels with suppressed PTH levels. And the diagnostic or the pathognomonic blood test will be low or very low ALP levels in this setting. Chronic immobilization, as may be seen in children with cerebral palsy, usually have reduced bone formation and like very similar to hyperphosphatasia, they will have hypercalcemia with high phosphorus and suppressed PTH levels. Management involves decreasing calcium and vitamin D supplementation and bisphosphonate, which are basically the anti-absorptive medication.
I think that's a very important point. Is that often patients with cerebral palsy or people who are immobilized, we keep on giving calcium and vitamin D as part of okay, we are trying to ensure that the bone health is good, but that may actually be detrimental. So if you give them too much calcium and vitamin D and they are not using it to form their bones because their muscles are not working, and when we discuss about bone physiology, we know that when muscles are working, sclerostin levels are changed and that is going to alter your bone formation. These individuals, they don't have muscular activity, their bone formation is reduced. So whatever is happening is that we have got increased resorption and we are not depositing, and that's where the calcium will go up. So you have to be very cautious in that setting.
Hyperparathyroidism basically acts at multiple levels to increase the blood calcium levels. From the bone, it will cause an increased bone turnover, thereby increasing the serum calcium levels. At the level of kidney, it will firstly increase the 1-alpha hydroxylase activity, which will increase calcium reabsorption from the gut, and at the same time, it will decrease calcium loss in the urine.
So all these changes will result in a case of hypercalcemia.
And also PTH is responsible for phosphorus loss. So it will cause hypercalciuria with hypercalcemia with low phosphorus. But because the sir has already mentioned that because your load of calcium delivered to the glomerulus is high, you will also see hypercalciuria, which is a relative hypocalciuria for the degree of hypercalcemia.
So for the same level of calcium, if you have inactivating mutation of the calcium sensing, you will have the least amount of calcium.
Yes.
If you have other causes of hyperparathyroidism, you will have less. If a normal individual develops the same calcium, you will experience much more. So although there is hypercalcemia and hyperparathyroidism, that's not a primary cause, it's secondary to the hypercalcemia. If you corrected hypercalcemia, they will become hypocalcemia. That's important.
And because of the increased bone turnover, it results in metabolic bone disease. So increased PTH effect can be because of hyperparathyroidism, which could be isolated as seen in CD73, menin and calcium sensing receptor defects. It could be part of syndrome, especially MEN syndrome. MEN1 is has 90%, like 90% cases of MEN1 will have primary hyperparathyroidism. 20 to 30 patients of MEN2A will have hyperparathyroidism. MEN2B almost never has hyperparathyroidism. Other causes are MEN4 and cyclin-dependent kinase 1B defect, or it could be hyperparathyroidism, which is sporadic, as seen in other, certain genetic defects.
I think one important point to remember here is that as against adults who are more likely to have an isolated lesion, which may be because of a somatic mutation, children and adolescents typically below around 30 to 40 years of age have more likelihood of having the genetic causes, which are more likely to be multifocal.
Yes.
And that's important because if you have a multifocal lesion, getting a scan and picking up one lesion and removing may not cure the disease, it will come back again. So that is something which is important to remember.
Increased PTH effect can be because of a sensing defect as seen with calcium sensing receptor mutation or antibodies in antibodies to the calcium sensing receptor. It may be also seen with familial benign hypercalcemia, which may be because of different genetic causes.
Very important to identify this is because even if you do a parathyroid surgery, earlier people used to do is that okay, you have hyperparathyroidism, PTH is high, and you've got high calcium, remove the parathyroid. Would the removal of parathyroid result in remission of hypercalcemia in this form, calcium sensing receptor defect?
No, these are often asymptomatic because
so
they
one,
have.
it's benign, and second, the other mechanism is your decreased renal excretion will persist. So you will not be able to cure their hypercalcemia. So these ones will be picked up on routine clinical assessment with marginally elevated calcium levels. Don't do much in this segment.
or increased PTH effect, maybe because of increased sensitization, as is seen with constitutionally active PTH1 receptor in Jansen's metaphyseal dysostosis, PTH-related peptide increase in Wilms tumor, and increased GNAS, constitutional GNS activity in McCune-Albright syndrome. An important and a severe form of neonatal hyperparathyroidism is seen with calcium sensing receptor mutation when both the parents are affected, either a homozygous mutation in child or a compound heterozygous mutation in the child, will result in severe hyperparathyroidism. Often the levels go up to 15, 16 levels mg per deciliter. It is an inactivating calcium sensing receptor in the 3q chromosome. Long arm of, and here it results in shift of the calcium PTH curve to the right. These neonates present with severe hypercalcemia, with relative hypercalciuria and a high magnesium.
This is a very important point to remember, is that often you will not see features of nephrocalcinosis and all because the calcium sensing receptor is defective. But if your levels are going like 20 and above, the filtered load is so much that you may still develop these features in that regard. So major presentation is in the newborn period with dehydration, failure to thrive. Those features are more common in that setting.
Since there is a receptor mutation, your PTH levels are also high. So despite hypercalcemia, there is an increased bone resorption resulting in fractures and metabolic bone disease. Here one may consider, one has to go for a family screening. In the setting of such severe hypercalcemia, hydration furosemide, which is basically a hypercalciuric drug, short-term cinacalcet is important, but the long-term or final step is the parathyroid surgery. Post-surgery, these children will have hungry bone syndrome, and therefore calcium vitamin D supplementation is essential in the post-op period. The benign form is the calcium sensing receptor mutation, heterozygous. These individuals will have hypercalcemia with hypocalciuria. Because they have hypocalciuria, they will often not have polyuria dehydration symptoms. And
so these are the milder forms. And often the problem is that you don't want to overdiagnose these individuals and subject them to surgery. Because if a surgery is done, that is going to cause more problem and confusion. It's not going to solve the problem. So this will be the milder form.
So these individuals will often not come with any presenting symptoms. They will be picked up on routine screening and will not benefit with parathyroidectomy.
So the important thing to identify this condition is when you have a neonate who is presenting to you with the severe hypercalcemia, get the urine and blood calcium checked in the parents. If both parents have hypercalcemia and hypocalciuria, you are most likely dealing with a heterozygous, compound heterozygous or a homozygous, a severe form where surgery and parathyroid removal is required. But if you are dealing with a situation where only father has hypercalcemia and hypocalciuria and mother is normal, this could be a transient scenario because this defect has come from the father and the baby was sensing the mother's calcium level is low. Now we always talk about the reciprocity in terms of the maternal level and the fetal level. So if the mother's sugars are high, baby sugar will become low. That is the infantodiabetic mother because of the homeostatic mechanism. Similarly, long-standing, I think that's one we did not include here, is that if there's a long-standing deficiency of calcium in the mother because of hypoparathyroidism or in the setting of vitamin D deficiency, the baby will sense that calcium low, produce more PTH and will develop hypercalcemia later. This is a very interesting scenario where the mother is normal, the calcium is normal, but that normal calcium is sensed as low by the baby because he has acquired the mutation from the father. And there will be a hypercalcemia with hypocalciuria, which will improve over time as things will settle down from that regard. So that's an important differential to look at.
As they have calcium sensing receptor mutation and the receptor also senses magnesium levels. So these children will classically have higher magnesium levels, normal to high PTH levels. Because of hypocalciuria, they will not develop polyuric symptoms or dehydration and will have no renal calcification. And again, no increased bone turnover or metabolic bone disease in these children. Right.
Thanks a lot, Dhwani, for this wonderful discussion. And now we'll move forward quickly about the assessment of hypercalcemia. The key questions to look at in this setting is it really hypercalcemia? What is the particular site and what is the individual cause to identify the diagnosis and management? So hypercalcemia basically will have multiple manifestations as calcium affects different parts of the body. It affects the bone strength, neurotransmitter stability and nerve function, cardiac contractility and conduction, release of enzymes. If your calcium levels go up, you will have release of more enzymes, which may result in a pancreatitis-like situation. It is also known to induce a ADH resistance, causing a nephrogenic DI situation and the gut motility. So if your calcium levels are going high because of hyperparathyroidism, you will have increased bone resorption, resulting in reduced bone mass. You may have encephalopathy with a very high level of calcium. There would be hypertension and ECG changes which are there in the cardiac system. You will have pancreatitis, which may be the classical manifestations. Polyuria, dehydration are more common in the setting of acute hypercalcemia, and this is a common presentation, as well as constipation. So these are the findings which may be there. Now, manifestations will depend upon the specific levels of calcium. Typically, till around 12 milligram per DL or 3 millimoles per liter, you will not have any symptoms. Till around 14, the symptoms of irritability will come up. Polyuria starts after 12, and that's a significant one along with hypertension. Typically, if you talk about acute presentation of hypercalcemia, you are dealing with severe dehydration. That's typically around 15, 16 levels of calcium, and then you have encephalopathy and seizures. So levels of calcium and the rate of rise of calcium makes it more likely about what sort of presentation we are dealing with. Neonates, often we will miss calcium unless we are measuring it. So if you have any neonate who has unexplained dehydration, polyuria, hypotonia or altered sensorium, when you're measuring sodium, when you're measuring potassium and your glucose, these are normal, get a calcium level checked also, because this could be the rare case of neonatal severe hyperparathyroidism, which may have huge implications on that regards. Children presentation and older presentation is different. We all talk about bone pain, abdominal pain, groin, and all those things which are there, a common manifestation. So abdominal pain and dehydration, unexplained hypertension, renal calcification. This is a common one. You get the renal calcification, then you check calcium and you find it to be high. And of course, if there is an unexplained metabolic bone disease, you will get that from that regards. Once you have these features, you will assess for calcium, which should ideally be done in a fasting sample. And it may have an issue in terms of albumin levels. If they are high or the protein levels are high, you will have pseudo hypercalcemia. And you can always correct that for the correction of albumin, which we have discussed earlier. So for every gram per DL increase in albumin, you have to add 0.8 to get the right calcium in that regards. There are specific criteria and cutoffs which are there for hypercalcemia. Neonates tend to have a lower cutoff. Post-neonatal period, you get a cutoff of around 12 milligram per DL, typically when you start getting worried. Now, once you have documented hypercalcemia, the next issue is the site, and the most important investigation in anybody with calcium disorders, be it rickets, be it hypocalcemia, be it hypercalcemia, is phosphorus. In the setting of hypercalcemia, if the phosphorus level is low, you are dealing with a PTH related cause, which is increasing calcium and decreasing phosphorus. And if it's high, it's a vitamin D related cause. Urinary calcium, again, you expect anybody with hypercalcemia to have a high urinary calcium. If your urinary calcium is on the lower side, you're dealing with a calcium sensing receptor defect. Always in the newborn period, get a family screening done for both mother and father to look for familial hypocalciuric hypercalcemia or familial benign hypercalcemia. Especially also look for maternal hypocalcemia. As we discussed, maternal hypoparathyroidism or long-standing maternal vitamin D deficiency causing hypocalcemia will cause the reverse scenario, like infant or diabetic mother has hypoglycemia. Here you will have hypercalcemia, which is transient. Alkaline phosphatase levels are expected to be high in individuals with increased bone resorption. If the ALP level is low, think of hypophosphatasia as a cause. Now, once you have a basic classification, you go for the confirmatory workup, look for PTH. Now, everybody whose calcium is high, you expect the PTH level to be low. A high or a normal PTH, a PTH level more than 20 in an individual with hypercalcemia suggests the diagnosis of a primary hyperparathyroidism, which is important. So it has to be a contextual scenario. If it's less than 20, then you can think of a PTH independent cause. Vitamin D level, of course, if your phosphorus is high and your PTH is normal or below 20, you do a vitamin D level, you will get it high in toxicity. Calcitriol level, if your vitamin D is normal, then you get at calcitriol levels. This will suggest a granulomatous disease like fat necrosis or other scenarios. And in very rare scenario, would you like to do a PTH related peptide? That will be in situations wherein you will have a neoplastic scenario, which can cause that. As discussed, always interpret the PTH level with regards to your calcium level. If your calcium is high and your PTH is high, it is of course hyperparathyroidism. And if your PTH is normal, it will be a problem in terms of a calcium sensing receptor defect. So this is something important. So the level of elevation of PTH is lower in a calcium sensing receptor defect as against the hyperparathyroidism. Remember that the high levels of PTH you see in the setting of secondary hyperparathyroidism like 200, 300 are rare in scenarios of primary hyperparathyroidism. If you have PTH in hundreds and you have hypercalcemia in an older individual, think of a parathyroid malignancy. That's a strong possibility to think of. Typically, the PTH is not very high. It will be like 50, 60, under 100 in that scenario. But any PTH about 20 with a high calcium is significant in that scenario. So hyperparathyroidism basically means you have hypercalcemia with hypophosphatemia and you've excluded all causes of secondary hyperparathyroidism, normal creatinine, because if you have long-standing renal disease, you may have a tertiary hyperparathyroidism, normal vitamin D, and you've excluded hypophosphatemic rickets as a cause. Now, once you have diagnosed hyperparathyroidism, whether you need to do a localization study, so for that you do is you basically decide about whether you want a solitary lesion and plan for surgery. So there is a SESTA maybe scan, which basically looks at a differential between the thallium and technetium. That differential can also give you the localization of parathyroid. In children and in adults below 30 to 40 years of age, we do not rely based upon the scan findings to decide about the surgery, because as I said, the likelihood of a multifocal lesion is more. The likelihood of a genetic cause is more. The likelihood of recurrence following removal of an adenoma is more in this setting. And if you have a single highly functional lesion, it will take up all the scan. And the other small areas may not be active in that regards. Once you remove this big area, you will have development in the other areas, which will then start developing in that regards. So scan typically after infancy and in family history you may consider. So technetium, maybe scan and subtraction study, as I discussed, will give you the diagnosis. So now if you look at the classification, we mainly look at hyperparathyroidism and calcium sensing receptor defect as common causes, as would be the granulomatous diseases and vitamin D excess. So as I discussed, if your PTH is high, you're dealing with a vitamin D related cause or a bone resorption related cause. If PTH is low, you're dealing with more of a parathyroid excess in that scenario. And the phosphorus level will give you a clue also in that regard. So PTH, if your PTH is more than 20, you are dealing with hyperparathyroidism in that regards. Everybody with hypercalcemia should have hypercalciuria. If you have hypocalciuria, think of a calcium sensing receptor defect, and other parameters will also give you a clue in terms of your alkaline phosphatase levels, which will be very low in the setting of hypophosphatasia, and you will get the diagnosis, and of course vitamin D levels, which will give you a clue. So the most important investigation here is the phosphorus, followed by PTH and vitamin D, and then you decide about your further workup in that regards. So to approach a patient with hypercalcemia, the first step is to exclude common causes like hypophosphatemia or decreased phosphorus exposure in a preterm neonate who is on TPN. Drugs like lithium, thiazide, which you have to exclude, immobilization in the setting of cerebral palsy, and look at PTH levels. If your PTH levels are above 20, which I discussed, suggest hyperparathyroidism, look at urinary excretion of calcium. If your urinary excretion of calcium is less, so you have hypercalcemia, high PTH, but hypocalciuria, you have calcium sensing receptor defect, you will find the magnesium level also to be high. Typically, hypercalcemia here will be mild. While if you have increased urinary calcium excretion, it's more likely to be hyperparathyroidism. In certain scenarios, like vitamin D deficiency, this hypercalciuria may be masked. So before making a diagnosis of calcium sensing receptor defect, if you check that your vitamin D levels are low, it may be better to give a course of vitamin D and see whether the urinary calcium is going up or not to identify the diagnosis. On the other hand, if your PTH is below 20, you should look at the vitamin D level. If vitamin D levels are high, it's typically a iatrogenic excess. In most cases, if it's normal, look at calcitriol. If calcitriol is high, think of a granulomatous disease like sarcoidosis, tuberculosis, lymphoma, or if you're talking about a neonate, you're looking at fat necrosis as a possibility. While if it's low normal, it's mainly an issue about bone formation or increased bone resorption. Think of a malignancy, think of hypophosphatasia, the rare cause, or think of a lymphoreticular malignancy, which we discussed in the first case scenario wherein you can have that situation. So just to summarize, the most important thing here is to, of course, look at the phosphorus level followed by the PTH level, which will give you the diagnosis. So we'll go through a few cases. 12-year-old girl with irritability, dehydration, and calcium is 18. So we are dealing with a very severe form of hypercalcemia. PTH level is on the higher side. So this looks like a primary hyperparathyroidism. What do you think, Dr. Dhwani, in this case?
So, because this is a neonate, one will have to look at the parents' calcium PTH status.
So you will look at the maternal and father's calcium and urinary calcium excretion, which becomes important. So here there is a relative hypocalciuria for the newborn. You expect at this level of calcium of 18 that the urinary calcium level should be much higher. So there's a relative hypocalciuria. Parents also have high calcium and low urinary calcium. So we are dealing with what form? So this is the neonatal severe hyperparathyroidism. There is either a homozygous or a compound heterozygous severe form of calcium sensing receptor inactivating mutation would require surgical intervention. 8-year-old boy with abdominal pain, Dr. Alapan, calcium is 13, phosphorus is on the lower side, PTH is 80. So what are you thinking about? Is this a PTH dependent or a PTH independent cause? PTH independent, but PTH is 80. PTH dependent cause. So now in this scenario, he was planned for surgery, but when you did the urinary excretion, it was found to be low. So what it suggests basically is that this is probably related to a calcium sensing receptor defect rather than a primary hyperparathyroidism. So magnesium here was also on the higher side, suggesting a calcium sensing receptor defect. So in somebody who is identified as a asymptomatic or mildly symptomatic individual with not very high levels of calcium, look at magnesium and look at urinary calcium before you make a real diagnosis in that perspective. And here you can use cinacalcet, which is a calcimimetic, which will basically decrease the effect, which will have an effect on the calcium sensing receptor, which will become more in that regards. 4-day-old boy with seizures, birth weight was 3.2 with asphyxia, calcium is 18, very high, phosphorus is 4.2. So how do you assess this sort of a relation of this calcium and phosphorus?
So here we, as you can see, the calcium is also high, the phosphorus is also on the higher side. So this looks like a vitamin D related cause. We do not expect an excess at day 4 of life so soon. So in the setting of birth asphyxia, one must look for purple violaceous nodules or
So important point here is that phosphorus is not low, making PTH dependent cause less likely. In this regards, PTH, of course, we will do. It was low. Then there was vitamin D level was low, but normal, but calcitriol was very high, and he had a violaceous nodule suggestive of fat necrosis. So again, in a newborn period, if you have hypercalcemia, look for skin nodules which can cause this granulomatous changes which are there. 15-day-old girl, preterm, 28 weeks of gestation, calcium is high, phosphorus is low. Is it PTH dependent cause? So you would expect the PTH to be high in this case. But there is a setting. This is a preterm child. So you have to start thinking of something else also in that. The PTH is 0. So it is not PTH dependent, but still you have low phosphorus and high calcium. So what are the possibility now? Dhwani had so nicely talked about this pathophysiology that if you have hypophosphatemia, you will have increased 1-alpha hydroxylase action, and this will result in increased calcitriol level, causing hypercalcemia in that setting. So this is because of prolonged TPN and phosphorus deficiency. It's not a PTH dependent cause. 10-year-old boy with routine workup, calcium is 10.1 and phosphorus is 2.2. Now PTH is 90. In this scenario, fractional excretion of calcium is 1.2%. So it's a borderline scenario. So this is a common presentation wherein the doubt is whether this is a familial benign hypercalcemia, because that's why you have got this mildish level of calcium elevation or nearly normal, and your urinary calcium is also slightly high, or is it truly a hyperparathyroidism? Because of vitamin D deficiency, this is being masked. So how will you go ahead in this case, Dhwani? Yes. And if vitamin D level is low, as in this case, what will you do? Yes. So we gave a course of vitamin D and the urinary calcium increased. So what it basically means is that this was actually a case of primary hyperparathyroidism. The severity of hypercalcemia and the severity of hypercalciuria was masked because of vitamin D deficiency. This is very, very common in our setting. So before you label anybody as familial benign hypercalcemia, for which nothing much is to be done, you should look at vitamin D level and give a course of vitamin D, and you will get the diagnosis right in that perspective. But then the calcium picked up. No, later on treatment, the calcium picked up on that. 2-year-old girl with abdominal pain, ultrasound showed nephrocalcinosis, calcium is 13.6, phosphorus is 6.2. So what is not likely in this scenario? So hyperparathyroidism is unlikely in this case, and you are more likely to be dealing with a vitamin D excess in this scenario. So PTH, of course, was as expected 0, and vitamin D was 200. So this is a very common scenario wherein there is a iatrogenic excess. Parents are giving too much dose of vitamin D, or the doctor has prescribed too much dose. It is usually because of injectable preparations, but sometimes if you continuously take the oral preparation, you will have this scenario, and this is vitamin D toxicity in that regards. 3-year-old boy with bone pain, calcium is 14.4, phosphorus is 4.4. So it's neither here nor there. PTH is undetectable. So this is a PTH independent cause. Your vitamin D is normal, calcitriol is normal. So what are you thinking here?
In the setting of bone pain, one needs to rule out a malignancy here.
So this is an important cause. So very importantly in this scenario, you have to think of a malignancy, and ALL is an important cause of hypercalcemia. You may see a lytic lesion which is causing, and you will find a lymphoblastic leukemia, which we discussed earlier in that regards. A brief overview about management. So what we can do in terms of options is try to take the calcium out from the blood. So what you do here is that you give a saline diuresis. So you give a lot of fluid. You may have double maintenance fluid. You give 40 ml per kg over 4 hours, and double maintenance normal saline. And only after hydration has been achieved, you give furosemide. Very importantly, do not give furosemide if somebody is dehydrated, because that is going to worsen the calcium level. So furosemide as against thiazide, which is retaining the calcium, is promoting calcium excretion. So you expect the calcium excretion to go up, and you will do a saline diuresis in that regards. So you give 0.9% normal saline, 10 to 20 ml per kg per hour, roughly double maintenance. And then after a few hours, you start on furosemide. You expect a decrease in calcium levels by 3 to 4 milligram per DL in that regards. In refractory cases, you may give prednisolone, which will decrease the conversion of 25 hydroxy to 125 hydroxy. So definitely this is the treatment of choice of vitamin D excess. In that scenario, you can use it. Then you can use other agents like calcitonin, but as I discussed, calcitonin is a minor player. It has a risk of tachyphylaxis. So this is something you can use for that perspective. You can decrease the bone resorption using bisphosphonate or denosumab, which is again a rank ligand inhibitor in this regards. And you can use a calcium mimetic like cinacalcet, which is going to work on the calcium sensing receptor, decreasing the PTH effect. So the major acute management is saline diuresis, followed by, if required, you can use bisphosphonates, especially if the renal functions are intact. You may also consider using steroids as a course, and cinacalcet can also be something which is used in that perspective. And finally, if you have a large lesion, you have to go ahead with surgery. So acute treatment is double maintenance fluid up to 3 liter per meter square, and furosemide, and you expect a decrease by 1 to 2. You give furosemide an additional 1 to 2, so around 2 to 4 you may decrease in the first day with these sort of treatments. You can use pamidronate or zoledronic acid as an agent. Pamidronate is preferred because it's a shorter acting one, so you will not have a very long effect in that perspective. And cinacalcet, which is available as an oral medicine, can be used in cases of hyperparathyroidism or a calcium sensing receptor defect. Calcitonin is available as a injectable preparation or an inhaled preparation. The risk is that this is a transient and tachyphylaxis will develop soon. The specific management includes cinacalcet and surgery for hyperparathyroidism. In fat necrosis, you will use prednisolone and bisphosphonate. So prednisolone will really affect in terms of decreasing the 1-alpha hydroxylase action. Vitamin B toxicity typically will give a course of 4 to 6 weeks of 1 to 2 milligram per kg of steroids. For granulomatous disease, again, like sarcoidosis, you can again give a course of prednisolone, which is going to be effective. So now what we'll try to do is that we will try to cover this regards to the various aspects of the case scenarios and the common quiz sort of scenarios which Dr. Alapan will look at. We will also need to have a look about the answers. So people can give answers also quickly in that regards. So you have given the answers as well. Okay. Okay. So we will, after every question, we will look at the answer. So all of you are requested to give the answers as well in terms of what you feel about the diagnosis. So Dr. Alapan, you can come forward.
Thank you, sir. So most of the cases are has been already dealt by sir and Nani ma'am. So I'll start with the quiz. A 2-year-old girl child who has apparently asymptomatic and having a high serum calcium of total calcium of 13.6 milligram per DL. So what would be the next best step in this case?
So what do you think should be done in this girl who has got a 2-day-old girl with high serum calcium? So people have started answering also. So I think we can see what people have written. So, so if anybody would like to put the answer there, we would like to have the inputs. So the first thing, of course, Dr. Alapan, what you're wanting to look at in that perspective is
the ionic level of the calcium. We should check whether the ionic level of the calcium is normal or not. In this case, it is almost normal in that scenario. So the main factor, as Sarah has already described, that it is the ionic calcium which is responsible for all the action of the calcium.
You have to look at the albumin level, which will give you the diagnosis. So this was a pseudo hypercalcemia which was there. So again, always check for the specific level. Do not worry about the level. So all of you are requested to put your answers on the Q&A box. Next question.
A 3-day-old boy, again, a asymptomatic child with no any kind of symptoms. And here we have done an ionic calcium which shows a higher level of 1.79 with a higher phosphorus and PTH level. So what would be the next step in this scenario?
So in this case, what you're seeing here is that your calcium is high and your PTH is inappropriately high or normal. More than 20, we said, is high. So what will be the next step in this scenario? Anybody would like to volunteer? Okay, carry forward.
So we have to check for the maternal calcium level, which was low in this setting, causing this hyperparathyroidism, causing this hyper.
Yeah, so Dr. Narendra has mentioned about parental levels. That's very good. And Dr. Bharani is talking about urinary calcium. So yes, both are relevant. We should look at the urinary calcium and we should also look at the parental level. So mother's calcium was on the lower side. So it's like the opposite of infant or diabetic mother, where mother's sugars are high, baby's glucose becomes low. Here, mother's calcium is low. And because of the response, you have got hypercalcemia in the baby. So this is something to look at. This is
Hypercalcemia of newborn and is ideally do not require any treatment. So the next case, a 5-day-old boy has presented with irritability with 2 episodes of tonic seizure. He had multiple episodes of skin nodules, violaceous skin nodules.
So I think you have given the diagnosis here. Yes. So you have got a newborn in the setting of hypercalcemia presentation who has got these nodules. So what are the diagnoses? I think quickly people can write up in the Q&A. This is something which we have discussed. So this is fat necrosis. Dr. Narendra is absolutely right. And Dr. Bharani is also mentioning, I think, the same fat necrosis. So this is a classical scenario. So if you have somebody who has birth asphyxia, has these violaceous skin nodules, think of fat necrosis as a possibility.
He has a high serum calcium level and phosphorus level. And so
very importantly, the phosphorus level is not low. It is on the higher side, which means that the body is producing too much vitamin D, which is retaining the calcium. And again, the treatment here would be?
The steroid would be the treatment.
A course of steroids for 2 to 6 weeks will be what we are looking at.
So next, a 12-day-old girl child, he has again presented with irritability and the features of dehydration. And here also the calcium level is high, 18 milligram per DL, and a high PTH level.
So this case is different from the other 2 cases that you discussed about. 3 cases looks like very, very severe level of hypercalcemia, and PTH level is also on the higher side. Yeah.
And the parents also give the history of mild hypercalcemia, both the parents.
So I think the diagnosis is done here. What will be the diagnosis? People will be able to answer. I think there are a few answers which have come up. So Dr. Shubha has also mentioned subcutaneous fat necrosis. Fat necrosis for this case, primary hyperparathyroidism. Dr. Panali Raman is talking about, yes, it's primary hyperparathyroidism, and more specifically, as Dr. Bharani has mentioned, this is a neonatal severe hyperparathyroidism, which is basically because of a homozygous or a compound heterozygous mutation in the calcium sensing receptor. And how will you manage this case, Alapan?
You have to go for the near total parathyroidism.
So first you have to stabilize. So you have to give hydration, give diuresis. You start them on bisphosphonate, maybe calcitonin, cinacalcet, all that. Bring the calcium levels down and then consider going for surgery. Now, in the rare scenario, if you had found that only the father's level were high and mother's calcium was normal, what will you do?
We'll look for, we'll wait and watch.
So you will do the conservative measures and then try to see whether in the next month or so the calcium levels go down. Yeah.
So next, 7-year-old girl child who has presented with abdominal pain and mother gives of history of frequent bedwetting. Initially, she was taken to a pediatrician for the view of a urinary tract infection and investigated thoroughly. But incidentally, we have found that their serum calcium level was on the higher side, 14 milligram per DL, with a high phosphorus level.
So again, you have a high calcium and high phosphorus, which makes a PTH cause unlikely. As you said, the PTH is 3.4. It is appropriately suppressed.
So what would be the next plan in this case?
So a young child who is presenting to you with hypercalcemia, hyperphosphatemia, and a suppressed PTH. Let's see what the audience, the participants would like to answer on that. So vitamin D level, Dr. Palari Raman, vitamin D excess, Dr. Shubha, vitamin D. So yes, this is a classical scenario of vitamin D excess, in which you will actually develop nephrocalcinosis very quickly, because if the calcium levels are high, there is no protective PTH to conserve the calcium, and you will develop nephrocalcinosis quickly. Yeah. Yeah, so it's vitamin D toxicity.
Again, a 12-year-old boy. He's a known case of cerebral palsy and has been bedridden for last 6 years. Now he has presented to us with abdominal pain and a history of constipation. His calcium level was high, phosphorus is on the higher side, and a low PTH level.
Again, a PTH independent form of hypercalcemia. The setting is very, very clear that you have an immobilized child whose muscle activity is less. The bone formation probably will be less. Now the questions would be, what are the cause or what are the treatment in this scenario? So we'll solicit responses from people on that regards. So this is clearly a scenario of immobilization related vitamin D, in which your bone resorption is more and your bone formation is less. That's why you have hypercalcemia. And how will you treat this scenario?
We'll try to give bisphosphonate.
So you can give a course of bisphosphonate, which will not only improve the calcium, will also have improvement in the bone health as well. So that will be the scenario to look at. So this is because of immobilization.
Now a 10-year-old boy who has history of weight loss and loss of appetite for the last 6 months and presented to us with features of abdominal pain, headache. On examination, we found he has a high blood pressure level, and investigation shows a high calcium level with high phosphorus level.
So hypercalcemia with hyperphosphatemia, undetectable PTH. So it's something else which is causing that. And you have given some clues about weight loss and loss in appetite. So what will the possible causes people will look at?
So we have considered for a CBNAT in this child.
So in this case, ideally you should look at the 25 OHD level and then the calcitriol level. Your 25 OHD is normal and calcitriol is high. You're looking at granulomatous disease. So tuberculosis would be a possibility in this setting. So think of a granulomatous disease in that perspective. We'll see what the audience was thinking about in that. Okay, carry on.
So again, a 5-year-old boy who presented with fever for the last 1 month, followed by 2 episodes of GTCS, which his parents rushed to emergency. And on examination, we found that there was presence of large hepatosplenomegaly with various lymphadenopathy. It is a contiguous lymphadenopathy in the cervical and axillary lesion. And also there is history of severe bone pain. We have done a calcium, it was showing high level along with a low PTH level.
So I think this again is a giveaway. We have already discussed this scenario in which you have got hepatosplenomegaly and you have got a significant finding which is there in terms of the hypercalcemia and bone pain. So there will be a lytic lesion there and a malignancy will be a strong possibility in that setting.
Now, a 12-year-old boy again presented with similar complaints of like hypertension and constipation. He has a calcium of high calcium level, 15 milligram almost, and a low phosphorus level with a high PTH level. So what would be the next best?
So now you have a hypercalcemia with a low phosphorus and a high PTH, which basically means that it goes more in favor of a PTH dependent cause.
So we have done a creatinine level, which was normal, and a urinary calcium to creatinine level shows a high.
So what are you thinking here, Dhwani? So there is hypercalcemia, there is hyperparathyroidism, and the urinary calcium is high.
Yes, so in this setting, we will have to look for family history of many syndromes.
So this is a primary hyperparathyroidism. So you have to think of all the genetic causes and other parameters to look for. So there will be a parathyroid adenoma. So I think I'd like to really thank Alapan for this wonderful scenario cases. The key message from this presentation is that you should suspect hypercalcemia in a child who's acutely sick, particularly if there's dehydration, constipation, abdominal pain, hypertension. Get a calcium level done. If your calcium levels is high, always check PTH levels simultaneously. If your calcium is high and PTH is about 20, it is hyperparathyroidism. Start working in that regard. Look for urinary calcium to differentiate familial benign hypercalcemia from hyperparathyroidism. If your PTH level is under 20, look for vitamin D levels. If they are high, it's usually iatrogenic. If vitamin D is normal, look for calcitriol. That will indicate more towards the possibility of granulomatous disease or increased conversion. If both PTH, vitamin D and calcitriol, they are all normal, think of an increased bone resorption scenario like immobilization, hypophosphatemia, malignancy in that setting. So identification of hypercalcemia is very, very important. At this point of time, I'd like to thank all of you for patient hearing, and all of you can go and have a look at our website, learning.society.in, with validated courses related to pediatric endocrinology, books, and mobile applications. So we will try to close now in terms of presentation, and we'll see if there are any particular questions there in that regard. So I think the question is from Dr. Bharani, who is asking what causes infantile hypercalcemia in blue diaper syndrome. Again, the issue is mainly in terms of the vitamin D related cause, which can cause that in that perspective. And so this was a good interaction on various causes of hypercalcemia. We will continue our postgraduate lecture series with the next session on rickets next month, which will try to focus about specific